Okay, I think we can get started. Good afternoon, everyone. Welcome to our a webinar on why can't Americans have better and cheaper healthcare? Exploring the innovation challenge. This is part of HBHI's webinar series, Conversations on the Business of Health. I'm Mario Machis, and I have the pleasure of co-moderating this webinar with my colleague, Emilia Simionova. Emilia and I are both economists and professors at the Johns Hopkins Carey Business School. We're also core faculty members of the Hopkins Business of Health Initiative. The webinar goes until 1 p.m. We will leave some time at the end to address questions from the audience. So members of the audience, please use the Q&A function to ask your questions, and Emilia and I will be monitoring that and collecting questions for our speakers. Today's discussion is about a question that really is central to American healthcare. Why doesn't healthcare in the US improve in quality while becoming more affordable, as we see in other industries? So it's our privilege to have two outstanding guests today, Jim Rebitzer and Bob Rebitzer. So Bob and Jim are twin brothers, identical twins, and they are the authors of a recent book titled Why Not Better and Cheaper? Healthcare and Innovation. Their book critically examines the unique challenges of healthcare innovation in the US. And in this conversation, we will hear from Bob and Jim about the arguments and insights they offer in the book. And by the way, both Emilia and I found the book amazing, and we are currently fighting for who is going to add it to our syllabus first. So let me introduce Bob and Jim. So let me start with Bob. Bob Rebitzer advises health systems, academic medical centers, health insurers, the government, and philanthropies on ways to improve the quality and lower the cost of healthcare. He's a senior advisor at Manhattan Health and a Distinguished Career Institute Fellow at Stanford University. He has a long CV, but formerly he was a partner in the healthcare strategy practice of Accenture and vice president of United Health Group, and currently he is chairman of the board of El Camino Health System. Welcome, Bob.
Welcome, thank you.
And alongside Bob is Jim Rebitzer. Jim is the Peter and Deborah Wexler Professor at Boston University in the Questrom School of Business, where he was the founding chair of the Department of Markets, Public Policy and Law. Jim is also a research associate at the National Bureau of Economic Research, also a very long CV, and he received, I want to mention this, the Healthcare Research Award from the National Institute of Healthcare Management, and also the Kenneth Arrow Award from the International Health Economics Association. Welcome, Jim. Welcome, Bob and Jim. We are really thrilled to sort of get into this discussion with you. Again, thank you for accepting our invitation and welcome. I want to start with this question so you are twin brothers. And you wrote a book together. So how does this happen? Like, how do brothers get on writing a book together, and what was the experience like?
Jim, you want to take it?
Okay, yeah. Bob says it's my fault. What happens is Bob was working at that time with a foundation that was trying to find cheaper ways to deliver healthcare to low-income populations. And it was I can't remember the specific application that he was working on. And after doing some research and trying to figure out sort of more cost-effective ways of developing sort of a new technology, I think it had to do with eyes. He's turned to me. He called me up because we always were talking, and he called me up and he says, it's really a shame nobody can make any money by cutting costs, by coming with a cheaper product. And I said to him, that can't be right. And so that followed were months of conversations, long conversations between us. And then one day, I think I was riding on a bus in Boston, and I said, I think we got a book here. Unfortunately, he agreed. So we decided to write a book that was kind of a mind meld of our two worldviews. His as somebody who's very close to how innovation actually happens in real world organizations, and me as an economist who studies organizations that try and sometimes succeed and sometimes fail to innovate. So that's sort of how the book started.
So the only thing I would add to Jim's story is that it's been one of the high points of my life, the chance to collaborate on a long project with my brother. You know, we've been together a long time. We never tried anything like this, and we had a ball.
We did have fun. That's right.
That's great. It's one of those stories that you absolutely need to know when you start reading the book. It sort of introduces it in a very different way from just, you know, picking up a book in the bookstore just because the title sounds exciting. And I did find the title very exciting, and I want to start there with the question of, you know, what do you mean by cheaper and better at the same time? And that usually doesn't go together. So can you briefly tell us what's the problem and why? What do you mean by cheaper and better, and how you go about digging into that?
You want to take this?
Yeah, let me take this one. Yeah, thanks. So our book is an answer to a question. How come healthcare doesn't get better and cheaper like the cell phones we carry in our pockets? And our answer is that it's too easy to make money with low value innovations and too hard to make money with innovations that reduce cost. And the reasons for that have to do with the way incentives work or sometimes fail to work in healthcare, the social and professional norms, and the way healthcare markets work or sometimes fail to work. And the reason we wanted to tell this story is typically people think about healthcare systems of having certain vital signs, you know, like sick patients, you know, and we think about cost, and we think about access, and we think about quality. And our interest was adding a fourth vital sign. We believe that a healthy healthcare system should regularly produce innovations that increase value for patients and for society. And that's what the book is about. That's why we called it what we did. And that's the question we're trying to answer.
So Jim, is there anything that you want to add to what Bob just said about the sort of overarching question of the book and the approach?
No, I think he pretty much captured exactly what we were trying to do.
In that case,
that's the elevator pitch of the book.
I have that's great. I have a follow-up question, which you know, both Emilia and I are economists, and we have many non-economists in the audience, and I think it would be interesting if you could give the audience like an idea of this. Like in the book, the way, you know, you start by showing evidence that the U.S. healthcare system has issues, and you talk about, at some point you talk about healthcare expenditure as a share of GDP, and now that's pretty high in the US compared to other countries, but also about the growth rate of healthcare expenditure as a share of GDP. Right. I think that those are two different metrics, and they're both interesting, and they both tell us something. Could you elaborate a little bit on that distinction and what we learned from looking at those two metrics in the US?
Well, should I take this back?
Sure.
So if you think about you know, the U.S. has high healthcare costs relative to the rest of the world. Everybody knows that, very high, and that's essentially a story of market power. People, providers, other players in the system bidding up prices because they have a lot of market power. We wanted to, and people are used to thinking about that problem. We wanted to get people to think about a different problem that's not unrelated, but it's not about market power, right? The book's not about market power. We wanted people to think about innovation and what innovation means in this sector, and the way to illustrate that, or rather, a metric much more closely related to the problem of innovation is the rate of growth of costs relative to GDP, and that. But interestingly, if our healthcare system, the book is about how to make the innovation system in healthcare more efficient, meaning producing more value at lower cost. Interestingly, though, if you make the healthcare system more efficient, that won't necessarily mean that you spend a smaller share of GDP on healthcare. The society might end up spending a lot more on healthcare as a fraction of GDP, just because they're getting so much more bang for the buck when by innovating in healthcare. And that's kind of the point. The point of the book is not, this book is not fundamentally about solving the level problem, driving down costs in U.S. healthcare, though it has implications for that. It's about how you make a healthcare system that innovates in ways that make society as well off as it can be. And there, the issue, it's really driven by, and you see that, or the way to address that is by thinking about expenditures as a fraction of GDP.
If I could add just one additional comment to that, sometimes people wonder, is our book about the U.S. healthcare system, or is it about healthcare globally? And our book really dissects the U.S. healthcare system, innovation, the way innovation works in the U.S. healthcare system. But this question of trend, so the high levels of prices in the United States is a uniquely American problem. But the trend problem is shared by all advanced economies. And so although our book dissects the problem in the U.S. context, I think the trend problem is one that is shared across the globe.
Thank you, Bob and Jim. In the book, this is just directly follows from this discussion. In the book, you argue that in the U.S. in particular, and I would argue in some other systems as well, our system rewards innovations that are of low value and fails to reward innovations that are of high value. So we call this the missing innovation problem. Can you explain what you mean by that, and just give some examples for us in the audience so we can visualize what you meant?
So I'd like to answer this in two steps. One me and one Bob. Okay, and the one I want to talk about, the one I want to start with, but I'm going to point where I would like Bob to take it. It's easiest to answer this in terms of examples. So one example that is really interesting is the problem of antibiotic discovery, where antibiotics are incredibly valuable things, and periodically, there's evolutionary and selection pressure for the bugs to evolve resistance, and it creates enormous value for the for the innovation system in healthcare to find new alternatives to these resistant drugs, new antibiotics. But it turns out that antibiotics are almost always money losers. New antibiotics are almost always money losers. The patent system isn't doing its job in this case of rewarding high value, very, very high value innovation. And the reason is very simple. Once you think about it, which is that what's the first thing you do with a new antibiotic? The first thing you do with a new antibiotic is you don't use it. Wise stewardship requires putting it aside. They also tend to be more expensive and tend to be no more effective against the non-resistant bugs than the old ones. So there's all kinds of reasons not to use it. But the incentives in the patent system, which are all market-based, and there's a lot of value in having market-based incentives, push exactly against that. You come up with a new innovation, you don't use it, your patent exclusivity expires, and there's no profits. And as a consequence, nobody's willing to undertake the projects. It's a real problem. There are other problems with the patent system that it's not just about antibiotics. There's always a tendency to game the patent system, to try to extend patents through sort of trivial innovations or patent thickets. There's even a word for it called evergreening. That's kind of a beautiful word for an ugly thing. There's tendencies to reduce for companies to purchase potential competitors and not develop the developing drugs, competing drugs and not develop them, because that enhances the market power they have over the drug they own. That has a funny name called killer acquisitions. There are others that we point out in the book. So the patent system often fails in various ways to develop things that have a lot of value, and also in costly activities that don't create a lot of social value. So that's the first part. The second part I want Bob to tell, because I think it's an incredibly revealing story. Tell the knee story, Bob. Tell us about knees.
Well, so I occasionally do some advisory work for Stanford University, informally usually. And I was approached by an engineer who had developed, pardon me, a way to teach people to change their gait slightly, and which would reduce pressure on the knee. And in his initial studies, he showed it could reduce the amount of pressure on the knee equivalent to about losing 20, a 20% reduction in body weight. And they asked, what do you think of the idea? I said, well, it's, certainly if it works as advertised, it seems like it could be a very, very important new piece of technology. If it could be a way to defer or even avoid the need for knee replacement surgery, which is one of the most common orthopedic procedures, very painful for patients, very costly for the health system. That could be you're addressing a real social need here. And then they said, is this a good business? And I said, that's another matter. Who's the customer? And if you sort of go through the lists, let's start. I said, well, let's see. Who would buy this thing? Well, payers would have a strong interest in an innovation like this. But payers don't buy medical devices, and they certainly don't like to tell doctors what medical devices to use. Okay, so maybe payers aren't the right customer. Well, maybe orthopedic surgeons, orthopods as they're called, would be customers for this. And I think orthopedic surgeons would be very interested in this because they care for their patients and they want to solve the problem of knee pain. But they're in the business of running very complex, hopefully high volume joint replacement factories. And so at best, their interest in something like this would be a sideshow. It wouldn't be their main, they wouldn't be a great customer for this. But what about health systems? Certainly health systems could be interested in this. Well, it turns out that the replacement of joints, of which knee replacement surgery is a very common component, turns out to be one of the most profitable operations, service lines that a health system runs. So if you keep going down the list, you find a potentially valuable innovation, and it's really hard to find a customer for it. And that's how innovations go missing in healthcare.
Can I add something to that? Can I add something to that story? Because the kicker, you can take it a step further and really sort of zoom in on the incentive issues, or at least one of the incentive issues we highlight. Let's imagine you're a payer, right? And you want to get physicians to orthopods or whoever to adopt this treatment. And how do you induce them to do it? As Bob just pointed out, there are a lot of problems, but one way to do it is you share the savings with them, right? Shared savings incentives. And in other parts of the economy, that would be a no-brainer, right? But in healthcare, it's really complicated because if I share the savings with I'm a payer, I share the savings with the providers for getting people to use this treatment. Well, the benefits don't accrue till 15, 20 years down the road, let's say, right? Because it takes a while for the changing gait to avoid knee surgeries, and therefore, and there's no way in the healthcare system, especially with our very fragmented system where people change insurers constantly, there's no way that the current insurer can capture those future savings to share with the current providers. So that time horizon problem, which is very prevalent in the US because of our highly fragmented payer system, makes the kind of natural incentive fix to the problem Bob outlined much harder.
Thank you. That's super insightful, and the conversation is resonating with the audience, because I see that we already have some questions in the Q&A. We'll wait until the end, but I just want to encourage the audience to just keep those questions coming. So in our discussion, we're kind of we're following sort of the structure of the book. You have, you describe the problem, and then you describe three sets of causes. One is in the incentive system. The second is in what you call professional norms, and professional and social norms. Those norms, of course, are important to create trust and cooperation, and also a certain predictability in workplaces and in interactions within communities. But in the book, you argue that in healthcare, professional norms are, in some cases, an obstacle to the adoption of innovations. What do you mean by that? Can you give some examples of that?
Bob, do you want to take this?
Sure. Let me answer in the positive rather than the negative. There is a brilliant social entrepreneur and physician named Diane Meyer, who, along with a number of colleagues in the early 1990s, really catalyzed a movement toward palliative care. And when they started off, nobody offered palliative care in the United States. It was pretty close to zero. And they developed a model for palliative care, and they developed a kind of social campaign for its adoption. And they've been remarkably successful. Now, there is hardly a major hospital in the United States that doesn't have a palliative care program. And that's even true for more remote and smaller hospitals. So they've had an enormous success in that. And they did that entirely by mobilization of professional norms. There is no financial incentive. Palliative care physicians work harder for less reimbursement. And they've been able to use the positive power of social norms to activate a whole new way of delivering care. And palliative care, by the way, just for people who may not be familiar, is a way of delivering care to seriously ill people that really broadly takes their needs to relieve suffering and in some cases for other benefits into account. So there's an example of where social norms were able to mobilize, in the near complete absence of financial incentives, a whole new service line. Now that is, as Diane Meyer and others will tell you, that's not sustainable. Eventually reimbursement for palliative care needs to rise to the level of the value it creates for patients and for societies and for health systems. But I think, so that's an example, it's a positive example rather than that example of the power of social norms, social and professional norms in healthcare. Jim, you want to talk about
a negative example?
Mini clinics?
Yeah. So a negative example where norms could get in the way of incentives to innovate are mini clinics, which were, you can ask yourself the question. These mini clinics,
what they are? What they are.
Mini clinics are essentially, you go to a convenient place, often in a retail establishment, and you can get care for a limited set of very common illnesses, earaches, that kind of thing, colds, and you're seen by a nurse practitioner, an advanced practice professional who is often operating autonomously and not under the direct supervision of a physician. And these things offer an enormous amount of convenience to patients, and they do so by. But so that you could ask yourself the question: why were mini clinics first introduced by pharmacies and not by the incumbent providers, the pediatricians and the family care docs? And a part of the story, a substantial part of the story, is that the model of the mini clinics, which is you kind of divide up into simple and complex treatments, and you kind of give the simple treatments to the advanced practice professionals, and they operate kind of autonomously or together with a computer algorithm, was very, very much contrary to the social norms of autonomous professional judgment that are centrally taught to physicians in med schools. And as a consequence, the physicians, rather than saying, wow, this is a great idea, this way I could expand my practice and I could find a way to deliver more value to my patients at lower costs, they mounted huge public relations campaigns to resist them. And the resistance, the campaigns were all about social norms. There's one of your former colleagues, Roman, I can't remember Roman's last name, did his doctoral dissertation about those campaigns, and it's quite interesting. So as you know, as good fortune would have it, the physicians lost this battle, and so the sort of obstructive nature of their norms in this case didn't end up permanently killing this new innovation, but it certainly slowed it down. And it just gives you a sense what in healthcare, norms are enormously powerful motivators. They have a very different logic than financial incentives. They can work in places where financial incentives break down, but they can work for good or for ill. And we have to pay a lot of attention to the kinds of norms and the kinds of professional narratives that providers tell themselves.
Yeah, this is super insightful, and I just the former colleague of ours who Jim was referring to is Roman Galperin.
That's it.
And I also want to thank Jim and Bob, because for one specific reason, the examples that they are given in today's webinar are not all in the book. Some of them are not, and that's great. It's great to hear, because we read the book, but it's also great to hear examples that were not. So thank you for that.
Thank you, Mario. But you know what? The one we left out about norms, where we spend a lot of time talking about in the book about norms, is all about Mario's research on blood drives, intrinsic versus extra. So read the book to learn about Mario's work. I hope we didn't do violence to the research, Mario.
No, thank you for that as well.
And the end notes as well. That's important.
Endnotes were fantastic.
Yes.
The book is self-contained, so a reader who doesn't want to dig into the endnotes doesn't have to, or the appendices. But the endnotes and appendices are super informative. Just thought I'd mention that as well.
And thank you. And for the rest of you, the book is really short. So
you
could read it.
And
you could read it fast. We designed it that way.
Speaking of design, my next question is about market and market design. So one of the causes that you identified behind the lack of innovation that would reduce costs and improve quality is related to market structure. So I wanna ask you about that and what you identify as the main factor that are hindering innovation in healthcare related to market structure. In particular, in terms of lack of competition, and you talk about barriers to entry. So what are the key factors that are driving the market-based barriers to improved innovation and lowering costs?
So
you want to get that one? Yeah.
So the key idea here in our discussion of competition is idea something called switchover disruptions, which is that anytime you have an innovation, or transformative innovation, the more you disrupt your ongoing operations, and that disruption of ongoing operations, because you're learning how to do it, you're learning what it means, you're learning its extent, you're figuring out the new division of labor and responsibilities and power relationships, and these switchover disruptions are, we argue, critical in healthcare, and they're critical for understanding how competition matters for innovation. So Bob taught me to motivate this by asking you to compare transformative innovations, minimally invasive gallbladder surgery, and the introduction of electronic health records. Right, they were both kind of introduced at the same time in the late 1980s. Electronic health records took a generation to be fully adopted and spread. Even in 2007, it was like 4% of hospitals had workable electronic healthcare record systems, and it wasn't until the federal government jumped in with all kinds of funding during the pandemic, and not during the pandemic, during the Great Recession. And as part of their stimulus package, that you actually jump-started, that's a concept I want to come back to. But you jump-started a a widespread adoption, right? It took, and this is in a period where everybody else in the economy was investing in information technology with no external subsidies. You didn't need a stimulus to get Walmart to invest in its IT systems, but the healthcare system did. Contrast that to gallbladder surgery. Within a couple of years of this this is a very important surgery. Lots of people have this surgery. Lots of physicians do it. And within a couple of years of its introduction, it was everywhere. So what explains that difference?
And
And
Jim,
we
I
argue,
just add, Jim's referring to minimally invasive gallbladder surgery.
thank you. Yeah,
Yeah.
that's right. Minimally invasive gallbladder surgery. MIG. Anyway, so the question is, why did one valuable innovation transmit so quickly and the other not? And the answer that we think is what we should be focusing attention on is switchover disruptions. That the gallbladder surgery, the physicians were essentially doing what they were doing anyways. And as physicians and as surgeons, they wanted to learn this new technique, right? This was sort of part of their narrative, they're part of their mission, that it was well understood. There weren't a lot of disruptions. Electronic health records work very differently. They change the way things are scheduled. They change relationships between patients. They change, physicians sometimes saw them even as an attempt to exert further control over them and to take away from them the autonomy, which is so precious to their and so central to their professional identity and enjoyable practice. So it was because those disruptions and figuring out, well, you were involved a little bit with Kaiser's introduction of their IT system. How long did it, I mean, it took billions of dollars and a decade to figure it out, right?
Yeah, what's remarkable about the Kaiser Permanente story is that they were actually a relatively early adopter of electronic medical records at scale, and they've continued to be it remains a source of competitive advantage for them compared to other health systems, even though they've been at it now for 20 years more. And the question is, why was Kaiser able to go faster and be an early adopter when other people struggled with it so much? And I think part of the reason for that has to do with the power of the Permanente medical groups, which are very large, multi-specialty medical groups who are very closely affiliated with the Kaiser Foundation health systems of hospitals. And so the switchover, they had to encounter many of the same issues that that others who tried to adopt electronic medical records encountered. But what was distinctive was the culture of the Permanente medical groups, which enabled them to see this as a way of furthering a professional value that they cared a lot about, which has to do with the prepaid group practice model, which at that moment was under threat, and they saw this as a way of making the prepaid group practice model really work. And they were right, and they placed a big bet on it, and the bet paid off, and it's still paying off for them.
So, and where this connects with market competition is, it's a funny thing about these switchover disruptions, but they're more costly the more if you're an entrenched incumbent with a lot of market power, because then what you're disrupting are highly profitable operations, right? And so you tend, because of these switchover disruptions, the entrenched incumbents will tend to be slower to adopt these new innovations like electronic records, unless, and this is really an important unless, Bob's point, they see their monopoly position being threatened and eroded, right? And in that case, they can move faster, right? But so there's a kind of interesting and complicated relationship between market power and this process of introducing a transformative innovation. And generally, most of the time, if the incumbents don't see their position as under massive threat, they'll slow walk it.
So yeah, so the idea is big, a lot of market power, big companies are making a lot of money doing whatever it is they're doing currently, big switchover costs, little incentives to adopt new innovations, unless there's little barriers to entry, so that there's a threat of entry from the outside.
Right.
So that's the
Yes.
so continuing with the structure of the book. Again, the problem, the causes, and then you offer a range of solutions to each of the causes that you identify. And for my next question, I want to read one question from a member of the audience, but I'm not going to ask you to answer it because so the question is this: if you were to redesign the US healthcare system, what would you change first? Keeping that in mind. I still want to follow sort of a structure. I'd like for you to tell us what you think, what changes in the incentive structure, again, following the structure of your arguments: incentives, professional norms, market structure. Let's start with incentives. What specific changes to the present incentive structures do you recommend so that we can begin to address the problems that you have identified?
Can I start with this one, Bob?
Yeah.
I wanted to, this is a good question. And the reason I wanted to jump ahead is because it made me think about a really important innovator at Hopkins that you have, which is Bruce Leff, who works on Hospital at Home. Hospital at Home is a set of innovations that allow you to deliver care to seriously ill patients who otherwise would be treated in the hospital. And there haven't been sort of real randomized trials of it, at least as far as I know. Bruce might tell me I'm wrong. But it looks like it delivers good care at lower cost to the right patients, and it probably also reduces this very substantial cost of having to expand hospital capacity to the extent that you could deliver stuff that would have been done inpatient at home. So it's a very promising thing. It's a really good thing. And I think they started working on it in the late 1970s. It wasn't until the COVID pandemic that all of a sudden Medicare changed its reimbursements and allowed for reimbursements for hospital home, and the thing took off. And it seems to be kind of everywhere now. And, great success to Bruce Leff for sort of pushing on this. But the economic question is really interesting. The US has this big private insurance system, right? And these private payers, in principle, they're not bureaucratically bound, right? They could have paid for a hospital at home years and years and years earlier. So why not? And the answer is, or at least the answer we propose, has to do with what economists call common agency, right? And it's a fancy word for a relatively simple idea. If there's a lot of upfront investment in introducing hospital at home, and if one payer decides they're going to pay for that transition, well, they have to pay all the costs, right? Because otherwise the hospital can't make the transition. And but if all the payers, right, that paid that hospital sort of made the decision together, those upfront costs could be split across many payers. And in that environment, often the best thing to do if you're a nimble, thoughtful, aggressive private payer is do nothing at all. And so this problem of common agency, where leads what could be a source of strength of the healthcare system in terms of innovation to be a source of drag and slow change. And they had to wait until there was a jump starter of last resort, Medicare, who was willing, because they're such a big payer, to pay in a way that would cover a lot of these startup costs. Only then did it make sense for the others to jump in. So one thing that we would do to make incentives work better is to recognize that there are issues in the healthcare system that make it mean you have to think differently about incentives. And one way you have to think about them is you need jump starters. You often, for big changes, you often need jump starters, and often it's the federal government. Doesn't have to be, but often it's the federal government that's in the position to be the jump starter. But you could imagine the private payers in my hospital home example coordinating with each other and doing their own jump starting. But then they have to have a narrative where they see that's part of our job to look out for these jump starting opportunities.
And they also have to have a large enough share of any given provider organization. In the absence of that, and that's where the fragmentation comes in. In the absence of that, the incentives don't work so well.
That actually, this it's a great follow-up, because I was going to say that I believe the VA was the first ones that adopted electronic medical records, and they've had them since the 80s, and they've been very well used, very well developed. Somehow that never took off, but in the VA, practitioners were using them in electronic pharmacy and so on since the early 2000s, and that's been working fantastically. It's never quite took.
Amelia, that's such an important point. That's such an important point, because the VA, a lot of the barriers to the adoption, in addition to switchover disruptions, there's a common agency problem with the adoption of new IT, right? That if I'm a payer and I pay for you as a provider to introduce new IT that makes everything more efficient, I'm also paying for improvements that benefit the other payers, right? And in that situation, it's often the right thing to do is not to do anything. And the VA doesn't have a common agency problem. It's the only payer.
Exactly.
And that enabled them to move more quickly.
Yeah. So
Similarly, Kaiser Permanente too, who some of these early adopters are advantaged to the extent they have this aligned relationship with providers.
And so there's a oh, Mario, go ahead.
No, I'm sorry. I was going to mention that there's a message from Bruce Leff, who's in the audience, and he says, "Hi, Bruce." He says, "Thanks for the shout out on hospital at home. Agree that common agency is a very significant issue. Never knew the term until the brothers Rebitzer identified for me." So I thought I'd read that.
We love that. That's why we have HBI.
Yes.
Yes. I have a great question from the audience that is also related to what I wanted to ask. So there's a question here that says, what is the current or upcoming innovation you believe will experience a barrier to adoption due to the influence of social norms similar to minute clinics? And I think you've answered some of this, not with a specific example, but let me just wrap around this, the question that I had, which was about how can we facilitate the integration of innovative practices in healthcare settings? Can we do something to sort of overcome this barrier, which I don't think is really a conscious barrier on behalf of medical practitioners? Is there are there some suggestions that you have thought about?
Let me thanks, Amelia, and the anonymous member of the audience. Oh, it's a great question, Jim. Can I
take it?
Yeah. So the thing that we're looking at very closely is, as is everybody else on the planet, is artificial intelligence, and we think that has the power to be a transformative technology in the delivery of care, in the discovery of new drugs, in many other, in every aspect of the system. However, we are concerned that the movement of artificial intelligence in healthcare may look more like the adoption of electronic medical records and less like the adoption of laparoscopic gallbladder surgery. And we're concerned about that because the way we frame AI, we tend to think about AI as being a replacement for physicians. We think of or providers. We can call up our AI doctor and they'll be able to tell us what to do. And if that becomes the narrative, and if that becomes the predominant approach, if that becomes what innovators are looking for, applications to do that, we think it would look a lot more like electronic medical records and take decades to adopt. We would suggest a different narrative, a different way of framing it, and that would be thinking about AA not as a replacement, but as a complement to human clinical expertise. And and that we and look for ways. The key to AI will be for providers to trust and for patients to trust that this is innovation that will make their lives better. And we would suggest the way to think about that is start with the back office. Think about the administrative tasks that threaten to turn the practice of medicine into a kind of data entry occupation. And if you can use artificial intelligence to relieve that burden, like for example, and there are people already doing this, improving the documentation of patient visits in a way that makes it not only more accessible and useful and easier for the physician, but also potentially more accessible and useful and easier for patients. Then we have a really powerful application and a good way to begin to work out the kinks in the system to build trust in the applications. So, but the key to it is the narrative, which is very closely related to social and professional norms. There's a company, and I may get the name wrong, I think it's called Nine, that took this approach to the reading of radiological screens. So, right now you go to an emergency room and you show up there, early in the morning or very late at night, and there may not be a radiologist on duty. There's a scan of some kind that's been taken. And often what happens is that scan is then sent overseas for somebody who's during working hours for them to read it and then sort of send it back, which can still take several hours. And, many people have talked about using the artificial intelligence to replace the radiologist, but Nine takes a different approach. To my understanding, what they do is they use an AI type application to take a preliminary read of the scan results, and they don't make a diagnosis, and they don't replace the radiologist, and they don't replace the attending physician. What they do is they simply say, based on what we've seen here, it's probably okay for this patient to be released to home and come back in the morning or to be attended to in the morning when a radiologist has had a chance and a physician has had a chance to review the scan. So that's a way of using the AI technology as a way to complement and makes life better for patients, makes life better for health systems, makes life better for practicing professionals, as opposed to a replacement. So, that's a technology that we're watching very closely, and we think has enormous potential. But we have to make sure that we adopt the right narrative, and we have to be sure that we take steps all along the way to build the trust of patients and physicians and society in the reliability and quality of these AI applications.
I love that answer. I thank you. That was great, Bob.
Why, thank you, Jim.
You took it in places I didn't expect. But
brothers. It's great to see brothers who agree on things. I have a brother, and we don't always agree on everything.
I'm about to gently criticize. No, I'm not going to criticize. But there's something to add, right? But Bob in his answer kind of wove in, right, the norms and the switchover disruptions, which kind of matter a lot for the competitive stuff. But it also, the example of AI also sort of illustrates how sort of the value of the general framework of the book. And the general framework of the book is, don't look simply at the gee whiz factor of the technology, right? You want to look at the institutions and incentives in which it's embedded. So Bob gave a great example of that when he talked about the knee example, but AI is a good example of that too. Let's imagine that AI, because it's able to sort of understand protein folding or whatever, it really accelerates the development of new antibiotics, which is the first example we talked about, right? If you don't solve the perverse incentives of the patent system, you're still going to have a backlog, a pile of unprofitable antibiotic new developments. So it's really important to be thinking in terms of all the dimensions that we're talking about, the incentives, the norms, switchover disruptions and competition, and not simply look at the gee whiz factor, because we live in a time of remarkable discovery. And the discoveries, the message of our book is discovery is not enough.
Yeah, I love that you mentioned AI, because we seem to be like on the verge of this revolution, but it's not obvious that given the current incentives and so on and norms and so on, that the trajectory will go in the best possible direction. So we need to be working on that. And in that spirit, like HBHI is comprised of faculty from 4 schools within Hopkins: medicine, public health, nursing, and business. So professional schools. Going back to the professional norms and also incentives, I guess, like what can business schools of medicine, what can we do? Are we doing the right things? Can we do things differently to sort of, help to address the issues that you have identified?
I think Bob should answer this question because
He's
I
not
only teach in
conflicted.
business schools. He's actually a product of them. So
I think there's a big role for both business schools and the schools that train medical professionals in these areas. In terms of business schools, I think that we need to teach business grads the skills required to work with medical professionals. Physicians and nurses and related professions are not engineers. Particularly physicians are sovereign professions with a powerful sense of what their professional obligations are. And the art of working with and managing alongside health practitioners is something that we don't teach people in business school. And if you can't figure that out, you can't get anything done in the healthcare system. There's somewhere in the universe an elephant's graveyard with the bones of enterprises, the bleached bones of the enterprises, whose founders said, healthcare is so screwed up, how hard could it be to make it work better? And the missing ingredient for these many failures is often a failure to understand what's different about working in healthcare. We don't teach that difference and it's teachable. You can teach it in business schools.
can
The
I
other
add something?
thing-
I'm sorry. Oh, you go. Go.
Well, the other piece has to do with medical education.
Yep.
We have a problem. Many of the late Uwe Reinhardt, who was a great healthcare economist and a mensch, used to argue that the foundational problem in U.S. healthcare is really an ethical one, a moral one, and that is that we are ambivalent. We haven't decided in the United States whether healthcare is a private good and let people use their money to buy what they like, or if it's a public good, in which case we all have a stake in the system in which making it work. And we go back and forth, we oscillate back and forth about where we are. That's not true in every country, but it's certainly true in the political culture in the United States. And we do an exquisite job of training medical professionals to be the advocates for their individual patients. But we generally don't do anything to teach them how to play that role of a steward of scarce social resources. And unless we do that, it really puts physicians in a very difficult position in terms of evaluating and dealing with new technologies. And I think we also need to train physicians in the process of developing, implementing, spreading new technologies. Again, it's something very teachable. Many physicians in their fellowship training get a scholarly year, and some people work in laboratories, and some people get an MPH degree. And I think we should be creating paths which will allow people to learn about technology and their programs are examples that are there as bright spots that I think we can build on. There's the Clinical Excellence Research Center, which is a center that I was affiliated with at Stanford. The biodesign program at Stanford, which teaches people how to design new medical devices, is another one. Texas A&M has something called the NMed program, which trains physicians in engineering skills along with their medical training. There are lots of bright spots out there, but we need to build on them in a more systematic way to enhance medical education. Have I answered your question? I went on longer than I hoped. Jim, you wanted to add?
Oh, I just wanted to add that Hopkins is just a natural place to do that kind of back and forth between med schools and business schools, and not just it's easy for people to think about the technological part, but the sociological part and the normative part that Bob was just describing. I think Hopkins seems like a natural place to build there.
And as the former head of the healthcare management program at the Carey School, I can tell you with some of our best students were medical students who are taking a gap year to do exactly what we're discussing, but we would really love to have many more of them and a lot more from Hopkins, because we've had people from other institutions, but not that many from Hopkins. We would love to get more. I wanted to pivot because it's getting on to be almost 1 o'clock. I just wanted to make sure we look at some of the questions from the audience, which are all fantastic. We went through some of them, but talking about market structure, I think there's a very important part here that we didn't really touch on that much, and that's the role of employers. So this is unique about the U.S. healthcare system, where insurance and really healthcare, the employers are so much more involved in this. And I know you're gonna probably go back to the common agency and so on, but how do employers figure in all of what we've been discussing so far, and what's their role in how do you see their role going forward?
Well, I think as a practical matter, as a practical matter, if you want to make change in healthcare, don't start with the commercial insurance companies. They are cautious, they're tentative, and they tend to be consequently slow-moving. If you start with large self-insured employers, they have a much greater appetite for change and are willing to move faster. So if you're an innovator out there and you've got a good idea, think about that market. The Medicare Advantage market is also another place. That's not a commercial employer, but it has some of the same features in that the incentives are right. They're capitated in terms of their payments from the federal government, so they have similar incentives, which is to do things to make care better and cheaper.
I think so. We are essentially out of time. I want to be respectful to everyone's time, and I want to. This is not a bad point to end. Actually, this wonderful discussion. I want to again thank our panelists, Bob and Jim, for writing a very informative, insightful book, and for today's conversation, which was really great. I want to thank the members of the audience. Sorry for not being able to get to all of your questions, but what we can do is we can collect them and share them with the speakers and perhaps get their responses. Thanks again. We can one more thing. You can find information on HPHI's upcoming webinars on the HPHI website, as well as recordings of our past webinars. Bob, Jim, thanks again. Amelia, this was great.
Thank you, everyone. Bob and
Thank
Jim,
you, Amelia.
Final,
Thank you.
final words.
Thank you, Mary.
Thank you.
Bye-bye.
Thank you for joining.
Bye-bye.
Bye-bye.